Okay, so hello everyone. Yeah, thank you all for joining us today for our session. We're doing this today with Dr. Tanjala Gipson, who we're absolutely delighted to have with us today. She is a real world leader in managing aggression and violent behaviours, and as you can see with the number of participants we have tonight, it's obviously a very important issue. Not only in the UK but across the whole globe in terms of TSC, which was one of the reasons that we were so keen to get Tanjala involved today, and we were absolutely delighted that she was able to say yes and join us in what will no doubt be a very busy time, and a busy time for everyone, of course, at this time. To Tanji to introduce herself, and then we can get it going. So I'll unmute you, Dr. Gibson, and then there you go. I'll mute myself.
Well, hi. Here it's around lunchtime. I'm in Memphis, Tennessee in the United States, and I know it's evening there. So good afternoon to those in the US and good evening to those of you in the United Kingdom. I am so grateful to be here today. I have to tell you, of all the things that I get the privilege to do, spending time with families is one of my absolute favorites. And so we're going to go over some topics, but we're definitely going to have time for questions. You can put them in the chat, or we can talk about them afterwards. But I'm just super excited to be here. I'm sitting outside at my house because we're actually quarantined. One of my sons was actually diagnosed with COVID. I passed it along to my husband, but fortunately they're feeling better. But then when we went to go get tested to see if we were all negative, then I was tested positive, and my other son. So we're a household full of COVID positive folks, but we are able to come out this week, and everybody's feeling well. And so we're really grateful for that. And so I'm going to share my slides. Let's see, share my screen. Here we go. There we go. Okay. Perfect. So can you guys see my slides now? Perfect. All right. So, oh, that's right. I forgot y'all were muted. Okay. So I'm going to turn off the video and then just go straight to the slides. So our topic for today, we're going to talk about managing aggression and violent behaviors. I have the privilege also of being the director of the TAN unit in Memphis, Tennessee. TAN stands for TSC Associated Neuropsychiatric Disorders. And what that is basically it's a part of our larger tuberous sclerosis Center of Excellence. And I'm able to see both children and adults with TAN concerns, either people who are wondering what the heck TAN is and just want to get a screening, or folks who are struggling and have an issue such as aggression and would like some help. Okay. So I usually end with a calming picture, but especially because of everything that's going on right now, I want to start out with just kind of setting the tone. We're going to go through some rough issues, but one thing that I want you to always consider, always keep in front of you, that the sun is going to rise and set, and there's always reasons for hope. Okay. So what is TAN? TAN, the formal definition, it's really a group of conditions. So it can be cognitive, behavioral, psychiatric, and this terminology was used to kind of bring it all together to kind of give us an idea of the entire spectrum. And so it can include aggressive behaviors, autism, intellectual disability, and psychiatric disorders. And here's another way of looking at it. Dr. DeVries came up with this umbrella here, and these different levels. So the behavioral level, the intellectual level, neuropsychological level, psychosocial, academic, and psychiatric. And then underneath each are examples of things that might be found within that level. And we're going to focus here with aggression, but just so that you know that aggression is just one part of a myriad of things that could possibly occur in TAN. And so when I say a TAN evaluation, what do I mean by that? In our clinic, what that means is starting by going through the regular history, but then focusing in on those TAN concerns. And the way we do that is we use this TAN checklist lifetime version, If you've never seen it, it's available free online. It's at the tsalliance.org. You can also just put it in Google and share it with your providers. And so I just want to kind of just briefly run us through it. And so here's this first section. It's all about early development. Here we go. It's all about early development. We just ask questions about that. And then section 2, we talk about current development. Section 3, this is where in our clinic, we spend the most time talking about.
I still can't hear it when you unmute.
We're talking about behaviors of concern. And even though they're listed as yes and no, what we typically do here is we want to know when did
settings. Have you got settings to go to see if you can see what level your volume is?
My volume's up.
Yeah.
I could hear him.
Yeah.
So we want to know, when did the behavior start? What are the
say we could hear the initial presenter, but not the. That makes a difference.
What sorts of things make them better or worse? And here are some more of those different behaviors that can be a problem. In section 4, we want to know if the behaviors add up to a specific diagnosis. Because people can have behaviors, but it doesn't mean you have a diagnosis. For example, with ADHD, the core symptoms of ADHD are hyperactivity, inattention, and impulsive behavior. However, if those behaviors aren't causing an impairment, then it's just features and not necessarily a disorder. So what we want to know here is, have any of these disorders been formally diagnosed? And at the end of this section, and the end of every section, we always ask, have you had further evaluation or support? And would you like to have further evaluation or support? Again, honoring the fact that sometimes something may be occurring, but as a family, you may decide that, hey, it's not that bad for us and we don't need any interference. In section 5, we talk about intellectual development, and we want to know whether or not an intellectual disability has been formally diagnosed or is suspected. Section 6, this is for school-age individuals. We want to know if there's any problematic areas and whether or not there's been support. In section 7, these skills are kind of what I consider some of the higher order skills. So memory, attention, dual tasking. For some individuals, it may not be applicable, but for others, these can be problematic. And then section 8, I call this kind of my nosy section, because sometimes in a medical visit, families aren't used to necessarily getting into these issues, but they can have an impact on family in other ways. And so we want to know if the individual themselves is struggling with low self-esteem. And then we want to know, how's the family doing? Is there stress between siblings? Are there stress between parents that are causing relationship difficulties? And again, whether there's been evaluation or support. And then after we kind of go through all those questions, then we want to know, how much have they impacted the individual or the family? And so 0 is no problems at all. We're just running through the daisies. 10 is the house is on fire and we really need help, or somewhere in the middle. And then in section 10, we want to know what your top priorities to work on next. Not what we think, but what do you think is important to work on first, second, and third? And for our clinic particularly, at follow-up visits, because I'm always focused on not just the initial evaluation, but then what happens next. And so at follow-up visits, we come back to this TAN checklist, and we want to know what's changed and why. Are any of the interventions we suggested working? Are the priorities the same? And we keep going in this manner until we see progress. So next I want to share with you, we'll call him Jack's journey. We published his journey in this particular article. It's just here for your reference. So Jack's journey. So Jack is a 17-year-old young man with TSC-associated autism. His parents report that over the years, he's become increasingly aggressive and self-injurious. But when he began to violently attack his younger brother and his mother, the family made the decision to place Jack in a residential school. His mother became pretty tearful upon remembering that initial decision. These behaviors continued in the facility, and after harming more staff than anyone in his state, officials decided to admit him to Kennedy Krieger Institute's neurobehavioral unit. And this is just a picture from Kennedy Krieger Institute. This is where I trained in child neurology and neurodevelopmental disabilities. And so I did my residency there, and then also started my first faculty position there. And their neurobehavioral unit is just one aspect of this pretty amazing place, where a team consisting of psychiatrists, neurologists, behavioral psychologists, speech language therapists, teachers, social work, everybody working together on behalf of children and some young adults with pretty severe behaviors such as aggression. So this is where he was admitted. And so once he got there, we took this approach, which is the approach that I take even now when tackling pretty serious behaviors, of kind of approaching the behaviors from a multidimensional view. So the first dimension is looking at the functional. So the question we ask with a functional assessment is what in the environment might be maintaining the behaviors. In Jack's case, aggression, he used aggression when he wanted to escape from transitions, academic tasks, daily living tasks, or if he wanted access to attention. If he wanted a hug, he might punch instead of just saying, I want a hug. But he also had self-injurious behaviors, and we couldn't find any environmental factor there. Secondly is symptomatic. What do I mean by symptomatic? So what can we treat medically? This is the functional is all non-medicine. Symptomatic is focused on medical approaches. So for him, he also had epilepsy. So we treated as epilepsy with oxcarbazepine and vigabatrin. And his aggression, which we felt was related to mood instability, we treated with lithium and acenapine. And then finally, it was organic. The key to treating and talking about managing behaviors in tuberous sclerosis is that we can never forget that we know the neurobiology of tuberous sclerosis. We know what's going on under the surface in the brain, and are making the time to figure out, are there medications that target that neurobiology that could be useful? And so in his case, he had an astrocytoma, which we targeted with everolimus, which is an mTOR inhibitor. And then the lithium, I only found one paper about this, but there was a preclinical paper that suggested that lithium might have some impact on mTOR2. And so this is his hospitalization. So initially we got baseline data. These are the meds he was taking. Extinction means after collecting data, we just kind of left them alone. And then they started behavioral therapy. Okay. Down here with the everolimus, this lighter part is where the everolimus trough levels or the blood levels were not quite therapeutic. As it darkened, here, this is the therapeutic range. And here's what we saw. With the vigabatrin, the trileptal, or the oxcarbazepine alone, these were the average severe seizures. So when we added everolimus, we saw a decrease in those severe seizures, and that rebounded once everolimus was stopped. This is tracking his self-injurious behaviors per hour. And as I pointed out, his self-injurious behaviors, we couldn't find a behavioral aspect for those. Here's everolimus again. This is in the subtherapeutic range, so the trough levels were pretty low. And this is when the trough levels went higher. We saw a reduction here. And so for Jack, his mom had one major goal. We weren't doing the TAN checklist then. It wasn't available at that point, but I still made a habit of asking what the goals were. And mom at that point of the hospital, she said, I just want him to be able to attend a function and not hit me. And so after his discharge, he was able to go to a party with his mom and dance and enjoy the party with no aggressions. So now let's come back to that same approach, this functional, symptomatic, and organic. Let's look at it again. Functional assessments asks why. Why is that behavior there? Also asks what happens when. So what happens in Jack's case, what happens when he wants to escape? He became aggressive. Formally, the way this information is captured is with a functional behavioral assessment by a person, a professional who's a board certified behavior analyst. And Luke reminded me to point out UK-based resources. And here's some websites that I've found. I don't personally know these individuals, but this is just what came up when I did a search for BCBAs. And here are just some websites that will be here for you guys, okay? Continuing on with functional. One key thing, let's say you can't find BCBA, or let's say, they're there, but they're not affordable, or they're not taking adults, or they don't want to take somebody with severe behaviors. The key thing is to figure out, track this data and figure out how often these behaviors are happening. And then we can start seeing if there's some patterns or trends. So these are just from some apps that I found. I haven't used these personally. And what I don't like about them is that there's a charge for them, but there may be some free ones as well. So this is one example of where you can chart behaviors. And the green is like kind of less severity, where the red is more severe behaviors. This is another app, Behavior Tracker Pro. But then let's say, you're not an iPhone person, or you don't feel like being bothered with apps, you could just use pen and paper. Another key aspect of functional assessments, and this is not a standard for a functional behavioral assessment, but we do need to know what an individual's communication is like. And so I would highly recommend a formal speech and language assessment. And in that speech and language assessment, let's say, you're like, well, I don't need that. My loved one speaks and understands just fine. They're verbal, it's not a problem. Among the individuals who are verbal, one thing that we are starting to notice is that there can be deficits in what I call pragmatic language impairment. And pragmatic language is kind of the glue that holds language together. So it's someone who might be very literal. They may not get jokes or sarcasm. They may be uncomfortable with kind of body language. And that can be hard too. So it's important to know whether or not that is present. Assistive technology. This comes into play for individuals who are minimally verbal or nonverbal. So, and that is a speech and language pathologist with extra training in assistive technology to help figure out, is there some device that might be helpful, or a picture system, or a button, or something to say where they can say yes and no. So we just kind of want to know what communication is like. The other thing that we want to know is, what is an individual's developmental functioning like? Again, that's not necessarily a standard for a functional behavioral assessment, but it is important. In the TAN checklist, we ask, what is your view of your loved one's intellectual ability? And it's important because if we're working towards a behavioral plan, we need to know, are our behavioral expectations acceptable for where your loved one is functioning, and for their communication level as well. So that information is used to draft what we call a behavior intervention plan. And here's some things about that. One is, it has to be developmentally appropriate. back to the question of intellectual disability or not, one quick way to kind of describe intellectual disability is an individual who is one age on the calendar, but developmentally, functionally is a much younger age. So if you take a 10-year-old child, but who thinks, acts, and behaves like a 5-year-old, that's a 50% intellectual disability. They probably have an IQ of around 50. And so although the child is 10, the expectation should be that of a 5-year-old. It shouldn't be, well, you're old enough to know better. Their knowledge at that point developmentally is that of a 5-year-old. And so our behavioral expectations should be in line with that. And so should the plan. Secondly, very important is consistency across environments. One of the hardest things is if you have a behavior plan and grandma decides, they don't need it. And granddad's like, well, you know, we're grandparents, we don't need to follow that plan. And so unfortunately, what the child learns is this plan doesn't always matter. And so when they go back home, or let's say in school where people are trying to do this behavior plan, it becomes really hard for them to maintain those behaviors because they think, well, I don't have to do it all the time, so I'm not doing it any of the time. Making sure the communication strategy is inclusive. There are many times when behaviors escalate simply because an individual can't communicate their wishes or desires. And so I think a good behavior intervention plan has a strategy for communication. How do we communicate with that individual? Be prepared when a behavior plan is in place for a behavioral burst. And what that means is a sudden escalation of behaviors. This is hard to endure, and for some families, causes them to, think about or rethink or abandon the behavior plan. Because it's like, well, heck, I didn't come to make things worse. But the reason this behavioral burst happens is because oftentimes individual is not accustomed to having a consequence for a behavior or not getting attention for a behavior. And so they say, well, if you're not gonna respond the way I expect when I, knock the glass over the table, well, heck, what if I throw the table out the window? I bet you'll do something then. So you can expect and prepare yourself for that behavioral burst. The good news is that if you're able to persist, you can overcome it and get on to the other side. Target triggers with anticipation. This is kind of one of the areas of emphasis for me, is what can we do? There's things that we can do once the behavior happens, but is there anything at all that we can do in anticipation? So if someone has meltdowns, for example, with transitions, can we prepare them for what's coming next with a visual schedule? Or if they're having trouble waiting, can we prepare them by saying, never forgetting the general medical. So pain is a huge one, including dental pain. So making sure that we've had checkups to check those things. Constipation can trigger some behaviors and aggression and reflux, just to name a few. But just making sure we've had a good general medical evaluation, and if needed, blood work as well. And I should have included this here. I had a young lady who had some pretty severe escalations of aggression with TSC. And she also had epilepsy. And we were just trying to figure it out because it was a light switch type thing. But then I watched her walk and I noticed that she had a new limp. And so I said, well, let's just check some blood work, and come to find out her vitamin D and calcium levels were dangerously low. And when we got endocrinology involved and got her supplemented, then her aggression resolved and so did her limp. So those deficiencies were coming from the anti-epileptic medications. And organic, what do I mean by organic? Back to the underlying neurobiology of TSC. Okay, this is going to be the nerdiest slide of the day, but this kind of shows what this dysregulated mTOR or mammalian target of rapamycin does in the brain. And just to briefly back up, mTOR, the protein kinase mTOR in TSC, if you imagine that it's like a light switch, and the light switch goes on when we're eating, our body's growing, our cells are dividing. Light switch goes off when we're fasting and we're sleeping. In tuberous sclerosis, that light switch stays on. And because it's on, and we don't know to what extent it's on in each individual, but these are the things that can happen in the brain, and these are on the bottom are the results of that. Now, one thing that's left out here is there's no mention of behavior. So we haven't proven the behavioral link between dysregulated mTOR and in TSC and like aggression or self-injury. But it is something that we suspect and something that needs to be proven in research. However, just to point out, everolimus or any of the mTOR inhibitors kind of work right here on this increased growth of neurons. And vigabatrin works to restore this balance of GABA and glutamate. And one thing just to point out about GABA and glutamate, again, a little nerdy analogy for you. So GABA is like the brain's brakes, and glutamate is like the brain's accelerator. And in TSC, unfortunately, there's too little brake and too much acceleration. And it accounts for an imbalance that's restored by vigabatrin. So what vigabatrin does is it increases the brain's brakes. And what we hope is that it'll offset this over acceleration. And it's particularly helpful in epilepsy. So what about COVID-19? You know, we're all dealing with COVID-19 right now. So some caveats here. We could have changes. A lot of us have had changes in our routine. You know, as parents, a lot of us have had some heightened stress connected to this pandemic. There can be illness, there can be unexpected death. And then just the unknowns, you know, like I know every place is different, but here where I am in the US, you know, they're doing phased openings and they're opening things, but as they're opening things, there's more cases. And so there's just a lot that we don't know, and that can cause more stress. So what are some considerations for that? Think about the schedule. So there should be a schedule if that works for your family, but I would say a loose schedule, not so rigid. The key here is thinking about backing up a bit on expectations. Make it visual and forgiving. It's okay if we don't have lunch like right at noon. And build in some fun, you know, especially because of all the stress of everything that's going on. Build in some bubble time or reading time, or just sit outside and look at the birds time. Naps. I'm a huge believer in naps. And then think about being kind to yourself. You know, there was a set of parents I was speaking to in New York, and New York was pretty hard hit. And they were concerned that they weren't doing well enough. And my encouragement to them is, you're doing fantastic. They hadn't left the house in weeks. They were doing fantastic. You know, so be kind to yourself and use kind words and kind to others, of course. And maintain your hope no matter what. So what about those of you who say, well, you know, Dr. Gipson, my loved one is not aggressive, but I want to be on the lookout. So early warnings. And one thing to say too is that although there's a high percentage of folks who suffer from aggression, there are people that will never become aggressive. So but these are just some warnings just to kind of be on the lookout for. So severe explosive tantrums, delayed communication, persistent hitting and biting, not just the occasional, but it seems to be almost a go-to response in a young child, and non-response to traditional strategies. Again, I have the privilege of seeing adults, and so when I see adults and I'm able to talk to their parents and try to get a sense of where this started, these are some common things that they share. They share that, you know, we tried timeout and, you know, it never worked. And they can just kind of trace back some of the early things that happened. So now I want to share this video with you. Let's see if I can get it to pull up. Okay. And this is about Terrence Hamilton. So Terrence is a young man with tuberous sclerosis who experienced some aggression.
Working on a skill to replace hitting for Terrence. Instead of hitting, we're working on hugging. Instead of hitting, we're working on touching our head, stop to think, breathe, take a deep breath, and then talking about how you feel. Okay, this is Terrence.
Are you guys able to see this video?
We can just hear the audio, not the video.
Oh, okay, because I didn't do it correctly. So let me stop share and then go to this new screen. I just thought about that. Yes, okay.
I wasn't sure if it was just my screen or not, but yeah.
No, that's right. Trying to remember my tech stuff. Here we go. Stop share. Screen share.
That's it.
How about now?
Yeah.
We're working on a
perfect.
skill to replace hitting for Terrence. Instead of hitting, we're working on hugging. Instead of hitting, we're working on touching our head, stop to think, breathe, take a deep breath, and then talking about how you feel. Okay, this is Terrence. He's trying to hide from mama, but I'm putting his camera on him. Okay, he's getting up. We're gonna get up. He's trying to hit. So no hitting. We're gonna hug. Yeah, see how they replaced that hitting? No hitting. We're gonna hug each other. Oh, deep pressure. Rubbing on Terrence's back, giving him a deep massage. He rubbing on my back. All right, it feels really good. It helps Terrence to really calm down. And also, we have to sit up, Terrence. See, it's hard for him to calm down. He can't calm down. We're gonna put our hand on our head. That means we stop and we think, and then we take a deep breath, and we breathe. Take a deep breath, and we breathe it out. And then we talk about how we feel. Terrence, you feel nervous. What's making you feel nervous, Terrence, this morning? He don't want to get up. He may be a little nervous about school this morning, sometimes due to having seizures. So I'm trying to get him ready, trying to get him to go to school. But first, we're going to calm down, and we're going to talk about his nervous feelings. So these are just some little tips that you can do with your kid to help replace hitting and to get him to talk about his nervous feelings. All right, bye-bye.
All right. Good deal. Now let me stop share here and then go back to the presentation. Here we go. Okay, everybody can see the presentation now?
Yep, we're all good.
Okay, perfect. And so Terrence is another example, and I like that clip because again, it emphasizes that functional aspect of behavior management. And so that was a technique that was working for them. I still see Terrence, and I'm sharing this video, with his mother's permission. And it's and now as he's gotten older, he's gotten interested in Rocky. So he loves Rocky Balboa. and he has the shorts and everything. And so now when he tends to want to become aggressive, what mom redirects him to do is practice his Rocky moves. So he's able to kind of practice in the air, and he has a punching bag at home. So he's not directing that aggression towards family. So going through these cases, in the time that we have allotted, may make it feel like some people's path to finding a strategy that's going to work for their loved ones is just straight. It just starts at this slide, and by the, sixth slide, they're all better. But the reality is for many people, it's more like this. We hit walls, we turn around, we come back, we go back to the functional, symptomatic, organic. Sometimes we have to take things away and restart. And the key to doing that is, one key is your team. This is a picture of my team. Unfortunately, Sherry is no longer with me. Like, she's alive, but she's just working with a different team now. But I work with an interdisciplinary team, and we put our heads together and we work on trying to find strategies and solutions, realizing sometimes the first thing we recommend works, and that's wonderful. But other times it can be back and forth. And so for each one of you, establishing that team for your loved one is going to be a critical piece to finding the right outcomes, or the best outcomes. So what are some take-home points? Help. Don't wait, even if mild. And this goes back to those of you who have young children, or there's young adults in your life and say, well, they've never been aggressive. It's not really an issue for us. What should we do? One thing is finding someone with whom to do your TAN evaluation with. That is a recommendation for everyone with tuberous sclerosis to have done at each visit, and if not, at least once a year, to talk about those symptoms with a dedicated amount of time. And then 2, identifying what are the resources in your area if you should need them. So just doing that research beforehand, just so you kind of know who's in your area. Leaning on your parents, extended family, professionals, just making sure, because sometimes there's a tendency to, especially with some of these behaviors like aggression and self-injury, and not everybody, but there have been some families I've come in contact with who don't feel comfortable going to family gatherings anymore, who don't hang out with their friends anymore, who don't share necessarily with their family. But trying to find those individuals that are going to be close to you that would actually support you and provide some help, even if it's just a listening ear. That interdisciplinary coordinated medical team is key as well. And then reaching out to the TS Alliance, TSC International, Regional TS Alliance, in this case, the Tuberous Sclerosis Association there in the UK. And social media. I know right now social media isn't the best place to be, but there are some pearls there. If you just can kind of filter through and figure out where there might be some helpful sharing. And I know there are some TSC specific pages and Twitter accounts that provide a lot of helpful information. And thinking about the opportunities, as we go through these things, just like you saw in the video of Mrs. Hamilton, there was a time when she and Terrence weren't in such a great place, but once they got to that place, she felt comfortable to share what she learned to help others. And to identify new treatment strategies, because we do need to figure out if some of these targeted therapies are going to be helpful for behavior, or do we need to look at other things as well. And pace yourselves. This is very key. Think marathon, think long-term, so that you don't spend all of your, it's important to work on these things, but it's also equally as important to rest as well. Expectations. So especially when it comes to choosing your team, make your expectations crystal clear before you know, spend a lot of money on an evaluation or or travel a far distance. You know, reach out to that team or the person you consider and say, hey, I'm having trouble with this. I need someone to help me in this way. Is that what you do? Don't focus on the worst. I've seen even some cases of the most severe aggression you want to imagine, and then also see them get better, okay? Because they can and will get better. So I appreciate your attention, and I welcome any questions.
Thank you so much for that, Dr. Gipson. I'll just highlight that everyone is on mute, so if anyone does have any questions, do just put yourself off mute, or if you're not sure how to do that, just maybe put in the chat box, and then I'll unmute for you.
Hi, Dr. Gipson. Thank you for that.
Absolutely.
That was so informative. And I have a question. I have an 8-year-old son, and
Okay.
I would classify his behavioral issues as probably mild, but I do see a lot of angry outbursts. And my question is that when he reaches, when he becomes a teenager,
Mhm.
could it be that his behavior, because of his TSA condition, his aggression could escalate, could intensify?
Yeah, so it's definitely possible that it could intensify, but it's equally possible that it could resolve. And so in your particular situation, my recommendation would be to look into resources for behavioral management in your area, and have those things available, and know kind of a key thing to know is what are their waiting lists like. So if he were to have behavioral escalations and you wanted to seek treatment, is the waiting list like a year, or longer, or is it short? And if it's one of those waiting lists where it's, oh, it takes us a couple years to get people in, my thought would be to just go through the process and have them connect with that team. You have that as a resource.
Oh, that's great. Thank you. Thank you.
You're
I'll have a
welcome.
look at that. Thank you very much.
You're welcome.
There's a question on the chat group, or there's
Okay.
two actually, Dr. Gipson. So I'll start with the first one. So thank you so much for sharing your knowledge and expertise, as well as tips going forward. I have a 11-year-old girl who is currently well and able with some mild signs under tanned, and now I'm more aware. Oh, what can we do and what to watch for? Thank you. I thought it was a question. It was just a comment. It's a nice question, a nice comment at least. The other comment is, do the behavior plans work for more mature adults? My sister is in her 30s and her aggressive behavior is escalating.
Okay, so I'll address the first question. So it seems like the question there was what to watch for if my loved one is considered mild. When we definitely see this split between quote unquote mild, TSC relatively spared is what I prefer, say just relatively spared, and more severe symptoms. Among those who are relatively spared, the three things that I always watch out for are anxiety, ADHD, and that pragmatic language impairment. And the way to do that is to kind of at least get the test evaluations annually. Consider getting a speech and language evaluation and neurocognitive, just so you kind of have a baseline. And then the second question, I'm so glad that someone asked that question, because a lot of people think that, this FBA, the Functional Behavior Assessment, Behavior Intervention Plan, those are from the principles of ABA, or Applied Behavioral Analysis Therapy. And people think that's just for children with autism. And it's just not. It's having a strategy for behavior is applicable to anyone who's having a behavior that's undesirable. And so I definitely have adults the oldest person in my clinic, I think, is 62. The oldest person with the most severe behaviors that we treated was 37. And I will say that in my older patients, it's taken me longer to help them get their behaviors under control, but I have definitely seen a reversal in them.
Great, thank you for that. That's helpful. There was one more question that's just come through. Our 9-year-old boy has been on citalopram for 6 months and risperidone for 2 years. Is this going to be lifelong?
It doesn't have to be. And that's why I emphasize the 3 dimensions of treatment. So the non-med stuff is going to be the thing that is the most important. And the medicine, it depends on, the key too is kind of what are we targeting, you know, because sometimes individuals end up on a medication regimen and stay on it for life, and people don't really consider what the target is. I personally haven't found the antipsychotics like risperidone to be helpful in the long run for individuals with tuberous sclerosis. And so it's a matter of talking to the professionals who prescribe to figure out what the targets are, and then what effects are you seeing, and then at some point making sure that the behavioral interventions are ramped up, and then doing a trial of peeling that back. So I don't consider that someone should be on medicines for behavior for life necessarily.
Great. Thank you for that, Dr. Gipson. Okay, so there is one more question as well. So is there any medicine available to control aggressive behavior?
That's a great question. Again, it depends on where that aggression is coming from. There are some individuals like who may have aggression, like the young lady I shared, whose aggression was entirely related to her vitamin D deficiencies. So it depends on where it's coming from. It's not simply a medication approach. It's kind of figuring out what's happening before that behavior, what's happening after that behavior, and then figuring out kind of what sorts of non-med things can we do first. And then if we do choose a medicine, what are we targeting? Is it because we feel he's anxious? Is it because we feel he has poor impulse control because of ADHD? Do we feel that there's mood instability? Is there a medical concern? So avoiding that rush to say, let's use risperidone for aggression. That's what we use, or some other medicine. But really trying to peel that onion and get to the root cause of it.
Great. That's a great answer. Thank you. We've got a few more questions. One from Carrie, who I'm going to unmute Carrie so she can ask herself.
Okay.
There you go, Carrie. You're unmuted now.
Oh, can you hear me?
Oh, it's very quiet.
Can you hear me now?
Yeah.
Yeah.
That's better. Yeah.
Brilliant. Okay. Thank you. Yeah, I have a question for Dr. Gipson. We are a learning disability and mental health support provider who is supporting a young lady who is 19,
Okay.
and she has been on everolimus treatment for the last 7 months.
Okay.
She has very impulsive, aggressive behaviour, but she'll have these in very short bursts.
Mm-hmm.
So she may be sort of very calm, interacting. She is non-verbal. With learning dis and the epilepsy, but she'll be very calm, interacting well, and then she'll have a short burst where she'll hit or bite or will pull hair of staff around her. It was more around sort of the behaviour sort of management of it, is because there's very sort of conflict sort of pieces out there that some say that you need to almost correct that behaviour by saying, you know, we do not hit staff, or reacting by saying let go, whereas others are very on the sort of side of ignore the behaviour because they're getting attention by reacting negatively. So I just sort of wanted to know your view on that.
Okay, that is a phenomenal question, Carrie. So it would depend on what she's getting out of it. And if at all possible for you guys to, even if you don't do a formal functional behavioral assessment, somebody to start taking data on what's happening immediately before the outburst. And it sounds like she's fine. And then somebody's hair gets ripped.
Quite often she laughs.
Okay.
Yeah.
And so I would say, you know, look at that data for yourselves for like a couple of weeks. And then think about, if it looks like she's laughing, my thought would be, but you'd have to get your own individual data, is that it's more of an attention thing, like she likes the let go or the scream, or, and if it is attention, then the solution is more so ignoring. But, and that can be hard. I remember being on the neurobehavioral unit, and there was a little guy, you know, sweetest little guy, and maybe he's like 4 or 5, and I just gotten there, and I was like, I wonder why he's here, because he wasn't, you know, doing anything. And he walked over to me and he held my hand, and I was like, oh, precious, we're going to be friends. And then he proceeded to take the biggest bite out of my arm I've ever experienced a day in my life. And the team lead, I was standing directly in front of the behavioral therapist, who said, don't say a word. That was the hardest. So as the tears kind of just fell down my eyes, I was able to move my arm and not say anything, because for him, he wanted a big reaction. So the key is that if she wants a big reaction, is to not give that reaction, still get to safety, and maybe staff need to be a certain distance from her, can't reach, and not give attention to that. But then also, there's no problem with there being a consequence. So if your data supports that it's more attention seeking, and if you're able to get out of it, ignore the behavior, and then as a result of that, she doesn't get any attention for 10 minutes, like she's in timeout for 10 minutes by herself, then that's appropriate too. But I would base it on your own data, and then working with your team, and then whatever you guys decide, making sure it's consistent in all settings.
Do you find that if because currently she's only on 5 milligrams of everolimus, do you find that if the dose goes up, that can help with agitated behavior?
So, you know, we don't have a lot of, we have really, I mean, hardly any data in behavior and TSC. I have some signal about the self-injury in TSC, but that needs to be proven in a much larger study. For aggression specifically, that tends to respond more favorably to some of the behavior interventions. Like in Jack's case, although he was taking medications, he responded really well to the behavior intervention for the aggression, because for him, it was escape and attention. Yeah. And once he couldn't escape, and once we taught him to get attention other ways, then he really, you know, kind of stopped. Do you guys have an ABA person on your team?
Yeah, we are using so the behaviour bits of intensive interaction team now, looking at sort of trying to put a plan together, because of the level of her behaviour. She burns out staff quite quickly. Yeah. But yeah, it's just sort of because she has the tube is on the frontal lobe.
Yes.
Yeah, there's sort of been talk that will sort of really affect the impulsiveness.
Yeah. And another thing, since you mentioned that with frontal lobe tubers or dysplasias, sometimes in those, it would be a discussion with those who prescribe her medications to think about some of the medicines for ADHD and impulse control. And as far as the everolimus goes, whoever's prescribing that, it's always wise to just check a level and see if it's in the therapeutic level or not. That's kind of how you can make sure that it's optimal, just for her overall TSC health. And you know, we can't make a behavioral guarantee about that, but if they're going to use it, it would be wise to use it in a therapeutic framework.
Okay, brilliant. Thank you very much.
Oh, you're welcome.
Thank you.
You're welcome.
Lovely, thank you. We have a few questions, but a lot of them are broadly around the same topic, so I'll try and put them together.
Okay.
So there's been a few questions around everolimus, everolimus, I can say it. So around everolimus. So basically, if there's any way in everolimus improving behavior in people who live with TSC, or any sort of distress and agitation, and also in self-injury behavior as well.
Yeah. And so with that, let me stop the screen share. Perfect. So with that, again, you know, we just need more data. I'm hopeful. I have seen cases where self-injury got better, but that's just cases. Like we need to get more information about that. So I don't want to say that it absolutely does work. You know, again, we're hopeful because it's targeting the brain, but we just don't have a full answer yet.
Yeah, great, thank you. It's just a few more now. So one person asking if we should also consider aggression and violent behaviours in females and around PMT as well, if there's anything around that.
You said PMT?
Yeah.
What's PMT?
So the time of the month.
Oh, okay. I guess I just don't call it that. That's all. I didn't want to make a mistake. So yes, we've definitely noticed some cyclical behaviors around that time, and that's another good way to do some behavior tracking. I have a handful, just a small handful of patients who tried contraceptives, oral contraceptives, and have found that to be helpful. But again, not enough to know for sure. So I would say if that is a cycle, you know, no pun intended, but if that is happening every month, then on the non-med end, even considering relaxing some expectations during that week, giving, you know, that person a little bit more space during that time. And again, you know, talking with the OBGYN about whether or not a trial of oral contraceptives makes sense for them.
Great, thank you. And it's really quite powerful as well to connect. You know, it's always so wonderful to connect the TSC community in general in the UK, but then when you're talking to people from the US, the UK, there's been other people as well on the call from different countries. It really is so powerful, and it reminds everyone, especially this time more than ever, you know, when people are feeling isolated and lonely, that there's things connecting us all. Yeah. Perhaps we could do a dedicated Q&A session. Yeah. At one point. Anne-Marie just read my mind. I think she's put it on the chat group at the same time. All that's have to say is just a big thank you again, Dr. Gipson. We appreciate it so much, and
it's
everything
my pleasure.
You do. So yes, and as I've said, this session will have been recorded. So if anyone wants to revisit anything, then do please keep an eye out for all other TSA sessions as well. So I'm going to call this sort of finished, and people are welcome to leave. What I've been doing every other time we've been doing the session is I've been keeping the session running, just in case anyone wants to sort of connect with friends or make new friends as well, because I know there'll be lots of people here who know each other or want to introduce yourselves to each other. So you'll see me go off, but do feel free to sort of to mingle afterwards. So yeah. So a big thank you, everyone.
Can I say one last thing?
Yeah, of course.
I really just want to thank all of you for being here. Thank you for your time. Thank you for your attention. Keep hanging in there. Keep reaching out, and never, ever, ever, ever give up. Okay, you guys be blessed.